why are we doing what we're currently doing? So my background is kind of, as you heard Shafi say, is kind of deeply steeped in the healthcare industry. I'm a clinician by background. One of the interesting things about IBM is you get exposed to lots of different industries. So I've been exposed to the automotive industries, to the financial industries, to banking and utilities, and seen how technology is transforming and reinventing those services. And what I've seen is broadly 4 themes emerging from those other industries. And I think they have a great resonance for healthcare. The first is around personalization, this really exciting transformation that I think all of us have seen, where content is personalized, it's adapted for us as individuals, and using novel ways of interacting with services, we're able to participate and contribute with our own content and interact in much more meaningful ways with service. So a whole kind of person-centered model of interaction with different industries, highly relevant for healthcare. The second is around automation, process automation, and the application of artificial intelligence and machine learning. Obviously, you wouldn't be surprised to hear me, who comes from IBM Watson, talking about the exciting opportunities that we've got in terms of driving efficiency, improving productivity, improving the safety and consistency of decision-making when supported by machine learning. And most other industries have massively capitalized on the opportunities of AI to improve their services. I happen to believe that healthcare is kind of important. I think, financial services and automation's very important, but I cannot think of an area that is more important to all of us as individuals than healthcare. We cannot allow a situation where healthcare is the last industry to get the benefit from artificial intelligence and emergent technologies. This is going to get contentious. It's early in the morning. I'm going to kind of try and wake you all up a little bit. So I've talked about personalization. I've talked about AI. The third is really interesting, and I call it semantic queries. But essentially, what it is creating a digital world that reflects the real world, i.e. linking data, disparate data sets around an individual and creating a more meaningful way of asking questions and getting insights and using data and intelligence to drive decision makings and in many ways service design. So if you're going to ask the question, is Mark Davies a good speaker? Kind of the old-fashioned way of doing it would be to give you all a questionnaire at the end and say, did he speak well? But imagine a world where we have much more disparate, much more interesting data sets of kind of places that I've spoken before, what people's emotional state might be, different kind of your social media impacts, and you triangulated using multiple different data sources in order to answer real-world questions, which ostensibly can be quite simple. Was he a good speaker? But if you're asking questions like, what are my risks of cardiovascular disease, or what kind of services should we use for severe and enduring mental health problems, or what is the experience of a young pregnant woman who's suffering from depression, then the linking of data and creating the opportunities of asking real-world questions of our insights is absolutely the secret to starting to unlock redesign principles in healthcare. So that's the third one, semantic queries. And the fourth one is really interesting, and for the avoidance of doubt, you're sitting in it at the moment, and it's the network effect. So it's the opportunities of harnessing digital platforms to frankly connect people who are like-minded and generate communities of interest of people to share experiences where the value of the group is added to by each individual that joins that group. There are lots of examples in our social and professional lives. But what's really starting to happen, which is really exciting, is we're seeing patient groups connecting people like me, people with similar experiences. We are starting to see the emergence of professional networks where people are starting to share using digital capability expertise. And we are starting, and the most interesting thing for me, is breaking down some of the artificial barriers, professional barriers between professionals, patients, citizens, carers, informal carers. And those distinctions are starting to become less and less relevant as these community interests get enabled by richer and richer digital platforms. That represents disruption. That represents a rethinking around the social contracts of care, the social contracts of wellness, and different ways of interacting. So those are the four things, that are the four principles I see in other industries, all of them highly relevant to healthcare. But you know what's interesting? Those themes that you see in other industries have not digitalized what those industries are currently doing. What they've done is they've taken digital capability to reinvent and rethink the model of care. The danger in healthcare is that we will do the former, that we will use digital capabilities to digitalize our current processes, and that will be a great opportunity missed. Now, I feel really optimistic because of a very significant change that is happening in how we think about healthcare, and I'm going to spend some time just taking you through it.
Good morning.
People call it population health management, but I think it is a global movement, and it's something that is probably one of the most significant shifts in thinking around health and wellness that certainly I've seen in my career. Let me explain to you what I mean by that. So if you ask, so I've got teenage kids, we're all doing exams at the moment, and you know, as a dad, you say, you know, it's really important you kind of read the question, understand what the question is, work out what the exam question is before you kind of start. And you know what? When you're an adult, so it is with healthcare as well. What's the exam question of healthcare? What exactly are we trying to achieve? And if you take a step back from healthcare, there was a very good piece written from the Institute of Healthcare Improvement. They described it as the triple aim, subsequently became ensconced as the quadruple aim. But in essence, the purpose of healthcare is to improve the outcomes across a population, i.e. help people stay well. It's around treating people when they get well, so improving the outcomes of individual care. It's about improving the overall experience of care and doing it within an increasingly tight financial envelope in a way that's sustainable. So that's what we're trying to achieve. So how are we doing? So that's the history of healthcare in the 30 years that I've been in healthcare. This poor woman who must have done this, who ended up all over the internet with her telescope. But that's kind of how it feels. So looking down the wrong end of the stethoscope. And what I mean by that is the conversation tends to start with an organization. It tends to start with a professional group, a set of professional standards. The conversation often starts, heaven forbid, with a contract, actually, or indeed a regulatory regime. So let's think about healthcare, let's think about well-being, and start the conversation there. That is the wrong end of the stethoscope. And the really interesting thing that's happening at the moment is people are starting to realize that the way to improve wellness and outcomes across a population is not to focus on the organizations. You can have a whole bunch of really well-run organizations which are financially sustainable, have high levels of clinical governance and clinical safety focus, and you won't necessarily improve the health of your population. The way to improve that is actually to turn the telescope round and think about the metrics of your population, to think about and start the conversation with the needs of a population, the needs and of the individuals and groups of that population, and think about the resources in an inclusive, eclectic sense of what we have, not necessarily just within healthcare, but across those populations. It's a really exciting shift. There are lots of very clever people in international healthcare policy scratching their heads and trying to work out how we implement this and how we make it a reality. But the really nice thing for me, who works in kind of digital health, is digital technology will be one of the key enablers to actually making this a reality. So let me talk you through what I think the components of this kind of significant shift is in terms of population health. And I describe it as having kind of three main pillars. The first pillar, not surprisingly, is around starting with focusing on the population. So focusing on the people. And the elements to that are first and foremost to generate a deep understanding around the needs, the priorities, and indeed the opportunities within those groups. And what I mean about that, so to take you back to semantic queries, this is about creating linked data sets. This is about creating a unified view around a population that allows you to break down the cohorts and groups within those populations and use those insights to design services based on a set of outcomes that you're trying to achieve, not the other way around. So our understanding around the opportunities of advanced analytics and computational maths in mapping out what those kind of needs might be in a population is starting to become a reality now. But you know what? There's something slightly embarrassing that kind of Shafi will struggle to accept here, if you don't mind me saying that. And although we're very clever as doctors, you know, if you look at the outcomes you see across a population, what we do contributes about 12% of the outcomes that you see. It's a difficult reality to accept because we like to think we're very clever and important. But actually, we have a pretty marginal effect in terms of overall outcomes. The rest of it is made up by our environment, our leisure facilities, transport facilities, our employment status, what our housing is like, the significant relationships that we have, the behavioral choices that we make in terms of the things we eat, how we spend our time, our genetic makeup, etc. So if we are serious about the exam question that I set at the beginning of this, we shouldn't be exclusively focusing on that 15%. We should be thinking about what sort of data sets will help us redesign and understand the opportunities for the other 85%. So it creates a much more open, a much more diverse, and frankly a much larger set of data to understand this fundamental issue around population needs. In fact, my own view is that the traditional thinking around electronic health records and medical data is going to be a tiny minority of the kind of data we use to drive the insights around populations. Social media, genomics, work around kind of the broader determinants of care around our environment will become much more important components of us baking this cake of design-based insights. Second is the one that's really important there is around value. And I mean that in two senses. First is kind of value from a kind of porter perspective, i.e. the outcomes that you see divided by the cost that you spend in order to get those outcomes. And in many ways, the kind of narrative, the public discourse, the political discourse, and indeed the patient discourse that we need to have around the design of healthcare, the currency of that is that value conversation. And there are many examples that when we have difficult reconfiguration or redesign conversations from a kind of service perspective, when we cast that conversation in the context of a value conversation, it's a much easier and less contentious thing to talk about. And I could give you many examples from around the world about how that's panned out. But there was another kind of interpretation of this term value, which is about kind of value from whose perspective. So if you think about value from a patient's perspective, that is different from value from a kind of provider perspective, an organisation or indeed a clinician, and it's and that is different from a kind of value proposition in terms of a population. So when we're thinking about value, it's really important that we are transparent and we're explicit around kind of value for who, how that's measured, and how we understand, frankly, how the costs are distributed and where the benefits are. I have a view that conversation kind of only really makes sense and only gets you to the correct design answer when it starts with and ends with the population. When it starts and ends with both the individuals within that population and that body that you're serving. And the third principle, which I think is really, in many ways for me, some of the most interesting, is this issue around transparency and participation. So working with communities, rather than seeing populations as being passive recipients of care, but actually tapping into some of the assets, some of the kind of wealth, some of the experience and wisdom that exists within neighborhoods, within communities, to start to crack some of the problems that we've got, using some of the community-based assets to address some of the kind of thorny issues around burgeoning levels of lifestyle illness, aging populations, and some of the challenges that we've got in terms of the shortfall of our capacity as a consequence of a lack of workforce. And there are lots of examples around how we can view communities as assets to solving the difficult problems around health and well-being using digital capability than, as I say, passive recipients. So that's the first and the kind of I guess the most important, focusing on people, focusing on populations. The second is around, frankly, the defragmentation of care. So coordinating care around an individual. None of this will come as a surprise to you, but the linking together of services where you put an individual patient at the heart of a redesigned service, and at the heart of how the interactions between systems actually interplay with each other. Fundamental to this model around integration is an understanding of individual risk and risk of safety, clinical or indeed financially significant outcomes happening, and us managing the resources that we've got in order to mitigate that risk in a cost-effective way. Third aspect of that is around the connection of kind of, frankly, what should happen with what is actually happening. And what I mean by that is taking the body of knowledge and evidence that we have around best practice, using computational maths and machine learning to read, contextualize, and present that information in the context of an individual patient. So a lot of the work we're doing in Watson Health is about thinking about how we can use decision support at the point of care, harnessing ability to be able to use machine learning and present decision making at the point that clinicians are having to make it, using the ability to contextualize and present in a usable way, in an actionable way, the insights that derive from that body of knowledge. The exciting thing about that is it starts to address unexplained variation, and it starts to explain the kind of gaps in care and the overlaps in care that we know not only there is significant cost, but there's also significant clinical safety risk. Now, what I said about the democratization of health and care as founded populations is obviously equally applicable to individuals. So as we start to think about the kind of emerging world of kind of apps and digital capabilities, to move us away from the rhetoric of individuals taking an active part in planning and participating in their care, and it actually becoming a reality. And I think one of the most exciting things about my career has been the emerging power and influence and voice and legitimacy of patients which I'm tempted to say, put your hand up if you're a patient, because we kind of forget it's us. We are those people. Using digital capability to have the authentic and the powerful voice that is patients having an active part in individual care planning. I think it's enormously exciting. Frankly, we have seen nothing yet. It is something that is just starting. So I've talked about the opportunities of focusing on populations. I've talked about the coordination of individual care. The third one, in many ways, is the hardest, and it is this. It's about politically, from a policy perspective, how do you take a 30,000-foot view of a system that was designed to run as silos and designed to start with professionals and organizations and turn it round and reinvent it so that it's now going to be focused around those populations? And this is hard, you know? There are bits of the world that are doing this quite well. This is what you might call place-based care. It's what you might call accountable care, integrated care systems. There are lots of different international examples of people trying to do this, some moving faster than others. But it is, I believe, completely fundamental to us meeting that challenge of sustainability and meeting that challenge of what the future of health and wellness means, to be able to stitch this stuff together. And it's about not just technology, which I think is very important. It's a key enabler to this, but it's around kind of how the money flows around the system, how you start to think about workforce, and not just clinical workforce, how you start to have an inclusive view of workforce that includes carers and patients, both informal and formal. It includes such issues around kind of governance, it includes accountability, and how across this kind of system we manage risk, both clinical risk and indeed financial risk. I have a strong belief that the kind of insights that we can derive using digital dashboards is the way to drive the kind of transparency and insights that will allow politicians and policymakers to actually design systems like this. And as I say, we're starting to see some of this emerging, and we're very proud in IBM in being involved in some of the real forerunners of rethinking healthcare in this way. Let me just kind of leave you with two final points. So I spent a lot of time talking to clinicians about population health management and around kind of the telescope, which end of the telescope. And this is the really simple way that I use of getting them to kind of keep on coming back to the correct end of the stethoscope. This is an unbelievably simple matrix, as you can see, of a way of kind of thinking about the exam question. Imagine 10 million people that you're providing healthcare for. If you divide those 10 million people up into these boxes, essentially kids, working age adults, people who are older, and then along the axis of kind of people who are generally well, people who've got one or more long-term conditions, and people who are complex for whatever reason, it naturally leads to a conversation of, okay, let's choose a cohort in one of these boxes. What are the care processes in these boxes that we would need? Let's say frail and elderly. So if those are the care processes that we need, in what are the core competencies that we need to deliver those care processes, and then what are the assets have we got in a community using digital capability to start thinking about that. Now that is a different way of having the conversation. That's a way of thinking about, so for example, in falls prevention, using voluntary befriending services. What is the role of kind of the fire service in helping identify trip hazards in a community? What is the relationship between kind of community nursing and A&E services for falls? So in many ways, this kind of way of thinking, these kinds of matrices, actually is a brilliant way of driving that design conversation. And as you can imagine, those boxes get smaller and smaller, and it gets more and more complicated as you start to dig further and further into these populations and have richer and richer design conversations. The key thing is you have those design conversations not to communities, but with communities. And I'll give you one final thought. This is my favourite way of explaining population health and this kind of shift that we're going. And it's this really critical shift from the world on the left, where frankly we do the same thing for everyone on the back of so-called uniformity, to a world where we're actively managing the needs of the cohorts in our populations to get what we want. And if I could just explain this in a few moments, what this is about is understanding the needs of these cohorts. So the height of those children is what their needs are. It's understanding the resources that we've got broadly in terms of our communities, and it's matching the needs to the resources, and this is the important thing, to get the outcomes that we're looking for. So this is about being really explicit about the outcomes. In this case, it happens to be watching a baseball match, but it's about actively managing those things, measuring those things, and proactively using digital insights to ensure that with the inputs of the resources, you're getting the outputs that you expect to see in a way that is equitable, fair, and effective. So thank you very much for listening to me to kind of describing that world. I think this is really exciting. I think it represents a transformation around how we think about health and well-being. And for this audience, digital technology is, I think, one of the real key enablers that's going to make this a reality. So thank you very much.
Thank you. One second. What a great start. A fantastic overview, Mark, on the issues around population health and putting into perspective for the discussions going forward. It's a question for me, really. Now, you've done a lot of work in Department of Health, you've had huge leadership positions, and you've kind of travelled and you're quite an expert on matters. Have you seen any solutions, potential solutions in other countries that we might learn from, that you might share with us, for example?
Yeah, no, so for sure. So I don't know who said that the future's here, but it's just not equally distributed. But it kind of feels like that. So I've seen lots of examples of bits of the solutions, and I've seen some kind of amazing work. And actually, frankly, over the course of today, we're going to see some really good point solutions that are really important components. The challenge is what you might refer to as system alignment. So where you get the kind of policymakers, the managers of organizations, the politicians, the public, and the regulatory regimes to all line up to kind of to create that world. Now we got some good examples. So I think there's some wonderful work happening in southern Spain around accountable care. There's some good examples now from the States in some of their more mature accountable care systems. And I'm very proud to say that in the UK, we've got some areas that are starting to kind of see the benefit of linking up and joining data sets and using insights to drive data. So it's happening, but it's early days. And I think a kind of important message is for us kind of not to lose faith with this, actually. This is the benefits of this are so great, and frankly, our populations and our patients are relying on us having the confidence to drive this agenda. It's not easy, but it's an important battle to win.
Great. Thanks very much, Mark Davies.